Perfect. Thank you very much. Thank you again for the invitation. I think the task that I am asked to review in the next 25 minutes or so is the question of whether MRD guided management is ready for clinic use. Again, my name is Parikh. I am at the Mayo Clinic in Rochester, Minnesota. These are my financial disclosures. So I'm going to tackle this question in these four sort of major learning objectives. The first one is, how do you really measure MRD and CLL? What is the clinical impact of MRD and CLL? And some other questions that come up in the clinic on a regular basis. And then finally, I'd like to wrap it up as what is my approach to MRD in daily practice in the context of a patient who's not being treated on a clinical trial. So the first question is, how do you really measure MRD in CLL? So I think everyone really is focused on MRD as a novel concept, that something has come about, at least in the field of CLL, for the past maybe 5 to 10 years. But I'd like to remind you that it actually is a very long-standing concept. I think for all hematologic malignancies, this is something that we have thought about as response to therapy. And the amount of measurable residual disease is important because as we treat our patients with standard treatments, we all want to know the amount of response that we have achieved after that treatment was completed. And this is usually in the standard IWCLL response criteria called as complete remission, partial remission, etc. And this is typically based on history, examination, bone marrow studies, and CT scans. However, in the last 15 years or so, particularly with the advent of FCR-based treatment, we've actually been able to achieve a lot of deep responses in our patients. And I think the challenge is, how do we measure these responses? And so I think as we ponder about the next technologies that are available at our fingertips to do something like this, I think it's important for us to have tests that actually satisfy many of these criteria. That these should be sensitive, that they identify small amounts of CLL. They should be specific, meaning they should be able to tell us what are CLL cells compared to other B cells in the circulation. They should be quantifiable, and they should be standardized. So a test that is run here at Mayo Clinic is exactly the same that is run back home for you. And it should be accessible, meaning that it should not have stringent sort of collection and transportation criteria. And of course, it should not cost a lot of money. And so one of the most commonly used tests to measure MRD in CLL is a flow cytometry study. And on your right, you see a typical pattern of how CLL cells are identified. And the most commonly used panel is the European Research Initiative on CLL, the ERIC panel. And I've highlighted the 8 markers that actually constitute this panel. And this panel can detect residual CLL cells at a threshold of 10 to the power minus 4, which equates to 1 CLL cell in 10,000 leukocytes. Now, obviously, there are iterations of these panels around. One in particular that we use here at Mayo is an enhanced flow panel, where there's a slightly different combination of markers, but we believe that this has more sensitivity. And of course, there are head-to-head comparison trials that need to be done to understand if this is truly the case. But one of the advantages is that this can actually detect CLL even after exposure to anti-CD20 or CAR-T-directed therapies. What about clonoSEQ? So I think you've all heard about the approval of clonoSEQ for CLL by the FDA. This is a next-generation sequencing-based method that tracks patient-specific clones. And so this is important to understand because each B cell goes through homologous recombination with VDJ sequences, and each B cell has a specific sequence of V, D, and J genes that are then combined to make a barcode for every B cell. And depending on which malignant cell has actually expanded and become malignant, you can actually track the sequence, and that would serve as a barcode, as a signature for that particular patient's malignancy. And that code really has expanded and has occupied the vast majority of the B cells in the patient's peripheral blood, and that identifies the CLL sequence. And so the way the sequence, the clonoSEQ report really is given out is that you have dominant sequences identified at the time of diagnosis. It could be one or two in some patients. It will tell you what the IGVH mutation status is for that patient. And then over time after therapy, you repeat this test and it will compare the dominant sequence prior to the start of therapy to the one after treatment and tell you how much CLL is left. So there are various pros and cons of each of these modalities. And on the left here are the flow cytometry tests that are available. Here, one of the important things to notice is that this really requires fresh material. It can be done on samples that are stored, but typically it should be processed immediately once the sample has been received. On the other hand, the molecular studies can be done at a later time point. The RQ-PCR, which is the allele-specific PCR, is a more complicated test and it's not easily available everywhere. On the flip side, it's important to remember that the flow cytometry tests really reports the quantitation of CLL cells as a percentage of total leukocytes. So when we say 10 to the power minus 4, it actually means one CLL cell in 10,000 leukocytes. Whereas the molecular tests on the right actually refer to the patient-specific copy number alterations that are present in the post-treatment sample relative to what were present prior to treatment. And that's again a percentage, but it is very powerful. And so there have been consensus guidelines now on how to report MRD in CLL, and these were published by Dr. Viada and colleagues. I think it's important to understand that instead of calling it as minimal residual disease, the recommended term is measurable residual disease. And the other important part here to highlight is that when you call it as undetectable MRD, it is very important to mention the test that was used to assess for MRD, but also to mention the threshold of positivity or negativity, because an undetectable MRD may mean different things to different people. And here they have now started quantifying it as calling it MRD4, MRD5, which really specifies the upper limit of disease detection. So having sort of talked about what some of the tests are that can assess MRD status in a patient, let's review some of the clinical data. So here I show data from the CLL8 and the CLL10 clinical trials. Just as a reminder, the CLL8 trial compared FC to FCR in patients with previously untreated CLL, and the CLL10 trial compared FCR to BR in patients with previously untreated CLL. And here are the PFS data according to the response status at the end of treatment with patient data combined from these two trials. And on the right are data that are broken down a little bit more in a more granular fashion. So on the left, you will notice that patients who are in MRD negative CR at the top in the blue curve actually do the best compared to patients in the red curve who are MRD positive but are in a partial remission. In contrast, you will notice that patients who are in MRD negative partial remission do better than those who are in MRD positive complete remission, suggesting that it is the MRD status that actually drives the prognosis of this patient population once they finish therapy. Now, if you break this MRD negative PR gray line into the type of patient responses, you will see on the right that it's really those patients who have MRD negative PR with lymphadenopathy in this light blue curve are the ones who do the worst, suggesting that residual lymphadenopathy is a marker of high risk of disease progression in a patient who has achieved MRD negativity but still has partial remission by measure of lymph nodes. So again, this is important in the context of chemoimmunotherapy that may still be used in some patients where I think MRD negativity really allows us to predict how a patient is going to do once the treatment is completed. What about the CLL14 study, that used venetoclax and obinutuzumab in combination and compared that to chlorambucil and obinutuzumab. And here you will see updated data from Dr. Al-Sawaf and colleagues at the EHA meeting, where the 5-year progression-free survival with the combination of venetoclax and obinutuzumab was about 60%. A reminder that all patients with venetoclax and obinutuzumab received therapy only for 1 year, and they all stopped treatment at that time point. So what were the MRD data in this study? Here you can see that on your left, the proportion of patients who achieved deep MRD negativity, which is defined as MRD6, was about 40%, and this is in the peripheral blood by clonoSEQ analysis. But as you then try to dissect as to how these patients start doing, you will see that in the middle graph over here, at the end of cycle 7, approximately 34% patients had MRD6, and at the end of 3 months following 12 cycles of combination therapy, 40% patients were over at the MRD6 level. And as you track these patients, you will notice that about 55% patients who had MRD6 at follow-up month 3 were already at MRD6 level at cycle 7, which meant that about half of these patients did not need any further therapy because they were already at the best response by the end of cycle 7. In contrast, about a quarter of the patients actually had an improvement in their response between cycle 7 and follow-up month 3, suggesting that serial MRD measurement may be more beneficial than a one-time look at what the MRD looks like. In addition, similar to the data on the left in the middle, here they looked at what patients who had detectable MRD at 3 months following the end of therapy, how many patients had increasing MRD levels, and that's about 50%, again suggesting that some patients may actually benefit from deepening therapy if they have not achieved MRD by cycle 7 of treatment. Here is a Sankey plot that actually shows the change in the MRD levels in the venetoclax and obinutuzumab arm by NGS in the peripheral blood in these patients. And you will notice that over time, which is not surprising, the proportion of patients in the dark green box, which is the MRD6 level, proportionately goes down. The IWCLL criteria actually recommend that we continue to use 10 to the power minus 4 or MRD4 as our threshold, and 4 years after completion of this treatment, roughly 18% patients continued to have MRD4 criteria by NGS studies in the peripheral blood. So what about overall survival? I showed you data about progression-free survival, but here you will see that end of treatment data by MRD status in the peripheral blood actually suggests that patients who achieve MRD4 in the blue curve on the top have a better overall survival within the venetoclax or obinutuzumab arm compared to those who do not, suggesting that I think these are early data. We don't have a p-value for this comparison, but it suggests that there might be even a survival benefit to the patients who are able to achieve MRD negativity, at least at the 10 to the power minus 4 threshold after fixed duration frontline therapy. So what about relapsed CLL? So again, we're talking in the context of venetoclax-based regimen, and the most important study in this era, in this particular group of patients, is the Murano study. As a reminder, this study compared patients with venetoclax and rituximab to bendamustine and rituximab in a relapsed setting. Median prior lines of therapy was 1. And here, in contrast to the frontline setting, venetoclax in the relapse setting is given for 2 years, along with rituximab for 6 months. And you will see, which is not surprising now, is that with longer follow-up, there continues to be a PFS benefit on the top blue curve with venetoclax rituximab compared to BR, with a median PFS of close to 5.5 years with venetoclax and rituximab. Now, again, if you break down the response of these patients who received venetoclax and rituximab, so all of these blue curve patients, according to the MRD status at the end of treatment, you will note on the top right curve that patients who were MRD4 in green had a superior progression-free survival compared to those in red who had high MRD status. And those in blue had an intermediate sort of MRD status, which here is defined as low MRD, which is greater than 10 to the power minus 4, but less than 10 to the power minus 2, and suggesting that this really is a continuum with respect to how patients do after end of fixed duration therapy, at least in the context of relapsed CLL. And then the same data here show in the bottom right about overall survival. There does not appear to be a statistically significant difference, although numerically there does appear to be an improved overall survival in patients who achieve undetectable MRD to the MRD4 level. Now, what happens over time? So amongst patients who are MRD negative, so this is the green curve from the prior slide, who are MRD negative in the 83 patients, you will see that from end of therapy, there is a median time of about 24 months or so for MRD conversion. However, we all know that in CLL, just by the mere presence of MRD does not mean that a patient needs to be treated. I think it really is time from MRD conversion to progression-free survival and actually needing therapy, and that's shown here in the bottom left curve. And another way of looking at this is 194 patients received venetoclax and rituximab, of whom 130 completed 2 years of ven-rituximab, 83 patients achieved undetectable MRD, and then over time, you will note that about a third of the patients remained with UMRD after 5 years. And in contrast, a third had MRD evidence without progression of disease, and then about a third had progression of disease who needed treatment. And so these data really reflect how powerful MRD analysis is at the end of treatment in our ability to predict how patients are going to do. And some of the patients who actually have MRD conversion have the usual high-risk characteristics, including TP53 mutation, del17p, or have complex karyotype, or have unmutated IGV8 genes. So what about the combination of BTK inhibitors and venetoclax? This study was led by Dr. Nitin Jain at the MD Anderson Cancer Center, and this is the first study looking at ibrutinib plus venetoclax, where 3 cycles of single-agent ibrutinib were given, followed by a combination of the two for 2 years, and 80 patients were treated. And you will see that when they did bone marrow analysis for MRD studies, at the end of each of these cycles, you will note that the MRD percentage that is undetectable in the bone marrow steadily keeps rising up until cycle 24, where roughly 62% patients are MRD undetectable. This is a phenomenal rate of MRD negativity in a previously untreated high-risk patient population. And so this study was then actually, the exact study schema was used in the so-called Captivate study, where 2 different cohorts of untreated CLL patients were studied. The first was the MRD cohort, where at the end of therapy, patients were either confirmed to have undetectable MRD or not. And depending on whether they had undetectable MRD, if they did, then they were randomized to either placebo or continued ibrutinib for a year. Or if there was no confirmed MRD, then they were continued with ibrutinib or the combination of ibrutinib and venetoclax. And here are the data about the patients in the MRD cohort, where of 149 patients who were eligible for randomization at the end of treatment, about 58% had undetectable MRD, and then those patients were randomized to either placebo or ibrutinib, and on the flip side to either ibrutinib and venetoclax. And you can see that the disease-free survival in the patients who had confirmed undetectable MRD was not significantly different between either continued ibrutinib or placebo, and we expect to see some longer follow-up at ASH this year. But this suggests that MRD is a very powerful way by which we can predict which patients are going to do very well, and they probably don't need to continue with any further treatment. And on the flip side, when patients did not have any achievement of MRD, Continued ibrutinib alone was as good as the combination, again, suggesting that we may not need to expose our patients to additional toxicity. Of course, these data need to be confirmed with longer term follow-up. Now, this is a fixed duration cohort in the same Captivate study with a very high rate of MRD negativity. And again, these patients have a very long tail with a PFS that exceeds about 90% at the end of 24 months of follow-up. So in the last few minutes, I want to talk about some of the questions that come up in the clinic all the time. So the first question that I sort of wrestle with is, do I need to check for MRD in the bone marrow, or is blood sufficient? Obviously, my patients don't want to get a bone marrow if they can avoid it. So in most studies, the concordance is about 85 to 90%. And this is at the MRD4 threshold, and this is important to remember. It is also important to remember that this varies by the type of treatment that a patient received. So if a patient received rituximab or obinutuzumab, the concordance is less because these antibodies are very powerful in removing disease from the peripheral blood, but not necessarily from the bone marrow. So in my practice, it's reasonable to consider beginning with a peripheral blood MRD assessment. And if it's positive, then you're done. You don't obviously need to go to look for disease in the bone marrow. But if it is negative, and if it has been at least 3 to 6 months since the last CD20 treatment, you may consider omitting the bone marrow because this may actually be a true finding. And in those patients who have received CD20 antibody, I think you can decide with the patient if you really want to pursue it. But like I said, the concordance is typically about 85% in that situation, which is, I think, reasonably good. So what about MRD6 versus MRD4? Now I said that, the IWCLL criteria continue to advocate for using MRD4. Here are data from the CLL14 study that actually show MRD4 versus MRD6. And so you will see in the red at the bottom is MRD4, where patients have an inferior progression-free survival. And then on the top right are the green, blue, and the purple curves, which is MRD4, MRD5, MRD6. And there does not appear to be any significant difference between these three, suggesting that at least at the early time point, it does not appear that MRD6 is a endpoint that we really need to strive to achieve. What about MRD4 versus MRD5 in a different trial called the CLL11? This study, I'll remind you, randomized patients with previously untreated CLL to chlorambucil, obinutuzumab, and chlorambucil or rituximab and chlorambucil. And you all remember that obviously the antibody-containing arms were superior to chlorambucil alone. But in a recent study published in Blood, the investigators actually showed that MRD5 was better compared to MRD4, which was better compared to patients who did not achieve MRD4 here in the bottom right. This is an early example. I think obviously we need longer follow-up, more studies to demonstrate the power of this. So I think until then, I would say this is intriguing and interesting, but it's not really ready for routine practice. What about BTK inhibitors? So if you have a patient on ibrutinib or acalabrutinib or
2 minutes remaining, doctor.
For example, I think you will notice that although the percentage of patients who achieve MRD negativity is higher with FCR, you will note that patients actually do much better regardless of whether they achieve MRD or not with ibrutinib and rituximab. And so I think this is a place where BTK inhibitors would work equally well regardless of whether a patient gets MRD negative or not. And then finally, I want to just emphasize about the Bowen regimen. So this is a triplet regimen where patients receive zanubrutinib, obinutuzumab, and venetoclax. And obviously, all of these patients achieved excellent MRD negativity, but they also looked at the delta of the MRD, meaning what is the change of the MRD, and did that actually predict which patients were more likely to achieve MRD negativity faster. And they were actually able to show this very nicely in this study, suggesting that again, it's the rate at which patients achieve MRD negativity that is more important. So I think there are many questions that are remaining to be answered. What about MRD-driven management? Other compartments that need to be investigated? and what should be the ideal threshold. And so, this is how I really approach MRD in my practice. I will obtain peripheral blood flow cytometry about 2 to 3 months after the end of treatment. Like I said, the ASO PCR is difficult to get. clonoSEQ is approved but is expensive, and I'm not sure if we really need MRD6 yet in routine practice. I continue to use the 10 to the power minus 4 threshold in this group of patients per the IWCLL guidelines. I do not routinely obtain bone marrows at the end of treatment because of the excellent concordance. And I really use MRD as a powerful prognostic parameter to predict how patients are going to do for PFS as opposed to the standard response criteria. And at the current time, I do not believe that our data are sufficiently mature enough for us to alter treatment duration based on MRD results. So I continue to give 1 year of venetoclax in the frontline setting and 2 years in the relapse setting. And finally, I do not check for serial MRD measurements either during or after completion of fixed duration therapy. So the question, if MRD is really ready for prime time in CLL, my answer is yes, but with all of these caveats. And with that, I'd like to thank you for your attention and everyone on my team here, and I'm happy to answer any questions.